project. They're based out of Richardson, Texas, and I'm really excited to be here and, like Kathy said, see a lot of our former patients and reconnect with everybody and meet new faces.
Thank you, Jen. So on behalf of the panel, I'd like to thank the board for putting this together, and especially Tony Chambers, who just puts his soul and heart into these events and works so hard to make them great events for all of you and all of the panel members. So let's please give Tony one more round of applause. So panel members, please speak loudly into your microphones as we move forward. Okay, so let's get started. I do have to do one disclaimer. As many of you know, I also work for Synovium Pharmaceuticals as their executive medical director as part of the development process for various medications for Parkinson's disease. So I need to tell you that today I'm not presenting on their behalf, and so any opinions are my own. So please take that to note. Also, I'm using this slide to counter all the comments in clinic from my patients who say, oh, you only work on one day, on Monday when I see patients. So the rest of the week, I am working as well. All right, so today's format. So those of you who have been to these events know that it's very interactive. We're not going to just be lecturing to you. We're going to primarily focus on exercise and diet in Parkinson's, but we're not ignoring Huntington's disease, Tourette's, dystonia, other neurological conditions. But the majority of people here have an interest in Parkinson's disease, so you're going to find that the focus has shifted slightly to that entity. But that doesn't mean you can't ask questions about anything. So please feel free to ask any questions you might have today. So those of you who have been here before know that the format is short presentations, some fast facts, as I like to call them, usually about 5 minutes in duration. We're going to do that about every 30 minutes, and I'm told we have till about 2 o'clock to get through our topics today. And so we're going to have various topics during those 5 minutes, and then you're going to have the majority of those 30 minutes each half hour to ask questions. We're going to ask questions to the panel and have interaction. So there'll be a number of individuals walking around with microphones to ask questions, so please raise your hand and someone will come and get the question from you. All right, so with that, we'll go over the general topics today. I've listed these 6, mostly an introduction about Parkinson's disease, as I said. We're going to talk about exercise, ways to motivate you, different types of exercises, some of which you're going to actually do. And then we're going to have some nutrition facts, some strategies for losing weight. And then Dr. Alvarez is going to take the microphone and go over what's new in movement disorders in regards to treatment from the pharmacological and device side. So that's the format for today. So let's start with the first topic, just to get everyone on an equal plane. So we're going to focus on Parkinson's, as I said, but again, any of the movement disorders you may ask questions about or engage the panel. So Parkinson's disease is a chronic, progressive, neurodegenerative disorder, and that means it affects the nervous system, not just one part, but many parts of the nervous system. And degenerative means that cells in the nervous system die. So that's the definition of Parkinson's disease. It's the second most common neurodegenerative disease in the world after Alzheimer's disease. And we estimate about 2,000 Parkinson patients in San Antonio, 1 million in the US, and 6 million worldwide. And so quite a prevalent disorder, and we're happy to be engaged in taking care of patients with Parkinson's disease and providing support to those who are involved in their care. The primary problem in Parkinson's disease, although it's not the only problem, but the primary problem is the loss of certain dopamine-producing cells. I gotta click every time, sorry. And these dopamine-producing cells are in the substantia nigra, and you'll see the brain has been cut in half, so we've sliced it down the middle, so half is lost, The other half is towards the right. So we're looking at the midline of the brain and the brainstem. And you'll see the part called substantia nigra. That means black substance, and it's black because of the deposition of neuromelanin that makes it black, and that's within the dopamine-producing cells. And there are two parts of the substantia nigra, a pars compacta and a pars reticulata. It's the pars compacta that loses the dopamine cells, but that's only part of the problem. It's the majority of the problem in what causes the movement part of Parkinson's disease. But there are other components of the disease as well, but just to give you a foundation insofar as that. All right, let's see. All right, so the Parkinson's disease diagnosis is based on history and examination. So what Dr. Alvarez and I would do in the clinic is take a history, go back to the time when everything was completely normal, find out what the first symptoms were and how they've progressed since that time. After we take the history of what's the problem, then we examine you. And we look for a number of different items on exam. And these are both motor problems and non-motor problems. We're going to focus mostly on motor problems today because we're dealing with exercise. But there are many other non-motor symptoms that we might try to elicit to see if they're present in a patient with Parkinson's disease. Things like anxiety, depression, sleep problems, other non-motor symptoms. But that's not involved in making the diagnosis. Those are just additional problems which may occur. So to make the diagnosis, we look for 4 cardinal motor symptoms. And I've listed them there for you. So a tremor, that's shaking, a rhythmical movement. It can involve the foot, the hand, the arm, the jaw, the head. And it's predominantly present when that part of the body is at rest. And it may dampen, actually, when you initiate movement of that part of the body. Not everyone will develop tremor, so 20% of patients never develop tremor. So yes, you may have Parkinson's disease without having tremor. The second is rigidity. Now, this is something we will feel on the exam. You may have noticed that Dr. Alvarez and I will move your arm or move your neck to feel a resistance to that passive movement. And that's what rigidity is. So that's an exam finding, not something necessarily you will complain about or your loved one would complain about. The third is bradykinesia. Brady means slow, kinesia is movement. So slowed movement is the third cardinal feature. And this is involving any skeletal muscle. So facial muscles, decreased eye blink, less facial expression. Soft voice is slowness of the vocal cords and other muscles involved in producing speech. Slowness of gait, walking, moving your legs slow, trouble getting out of a chair, trouble getting out of the car. Those are all symptoms of bradykinesia. And then we will look for balance problems or postural reflex impairment. So the diagnosis is made on finding 2 of those 4 features, as long as one of the 2 is either a tremor at rest or bradykinesia. So that's how we make the diagnosis. Any kind of lab test or MRI is done in conjunction, looking for other things. MRIs don't make the diagnosis of Parkinson's disease. Sometimes we'll order a DAT scan, that's D as in dog, A-T, to look at the transport of dopamine in cells in that part of the brain that I showed you on an earlier slide. But that doesn't make the diagnosis either. It either supports this clinical diagnosis or doesn't support it, but it doesn't make the diagnosis. So it's important to recognize those distinctions. So this just gives you a natural history graph of Parkinson's disease. Oftentimes, many symptoms will start before these classic motor symptoms. I've listed some of them on the slide. So the REM behavioral disorder is acting out your dreams, vivid dreams, hitting, moving, yelling in your sleep. That often can predate many of the motor symptoms that I've just gone over that are essential for a diagnosis. Depression, constipation, anxiety, loss of smell, which is hyposmia, all of that might precede the cardinal features of bradykinesia, rigidity, and tremor that are necessary for a diagnosis. As the disease progresses, there may be other symptoms: fatigue, pain, apathy, trouble thinking, urinary symptoms, balance problems, hallucinations, memory problems. On the bottom of that slide, the non-motor, and on the top are the motor problems. So ups and downs, the medicine works and then wears off. So fluctuations, trouble swallowing, and balance problems. So this is not necessarily intact for every patient. So some patients never develop any of these other problems, and others develop some. So this isn't necessarily the natural history for every patient. And if you see one Parkinson patient, you've seen one patient. Every patient is different, and if you discuss at your table what you're on, I suspect none of you will be on the exact same treatment regimen, because every patient's diagnosis and treatment are somewhat varied. And so please keep that in mind as we talk about things. So I just wanted to give you this overview slide, which has a dopamine-producing cell. That's the main thing in the middle. The orange is the barrier between the blood and the brain. And this really goes over every drug treatment that we have. So you take levodopa, which is outside of the brain, it's in the body obviously, it has to cross the blood-brain barrier, get into those remaining dopamine-producing cells. Remember, those are the cells that slowly die as part of the disease. So whatever cells are left, that L-dopa has to get into them. It's converted from L-dopa to dopamine. Dopamine is stored. It's released. Those are the little dots in the white space. And then it acts on other cells to produce normal movement or facilitate normal movement. Dopamine is metabolized by certain enzymes, and drugs we have affect those enzymes. And so this is give you a little foundation as we talk about some of the reasons exercise is important. It affects this system, believe it or not. So keep that in mind. We'll bring back this image in the future. All right. So just to wrap up here on this part of the fast facts. What are the risk factors for Parkinson's disease? We always say, well, did this cause my Parkinson's disease? Well, we don't know the cause of Parkinson's disease. And so things have been associated with an increased risk. Two things are advancing age. As we get older, the risk of Parkinson's disease goes up. So age is a risk factor. And having a family member with Parkinson's disease increases your risk. These are the two most well-established risk factors for Parkinson's disease. There's other things of interest: exposure to pesticides, exposure to well water, Agent Orange exposure. Those are of interest but not been clearly demonstrated to increase risk. These are the two main items. Now, believe it or not, there are some protective effects, some of which I would not necessarily recommend, but these are associations also that have been found. Smokers have a less risk of Parkinson's disease. There may be many reasons for that, one of which may be the effects of nicotine on the brain. So that's one potential reason for a protective effect. Caffeine, so drinking coffee, has been associated with a decreased risk. And exercise, and that's why we're focusing on that today, since we focused on other treatments at our other symposia in the past. All right. So we're going to focus on non-drug treatments today, although Dr. Alvarez is going to give you some updates on things that are in development. This is the last slide of this section, so get your questions ready. So non-drug treatments have to be tailored to specific needs, and we're going to hear about that from our physical therapists. Not every exercise is appropriate for every patient, and some assessment may need to be made before you engage in some of the activities that we are going to talk about. Any kind of non-drug treatment, including exercise, needs to be associated with education, and that's our goal today. It is, however, established, and you'll hear more about that, that physical activity is essential for overall health and prognosis and progression of the disease, not only in Parkinson's disease, but in life in general, and we're going to give you some information about that. Also, a productive occupation, whether that be work or other mental activity, and Dr. Garcia will be commenting on this, is also essential to treating Parkinson's disease and other neurodegenerative disorders. And the last line on this slide is what you need to take home. Prevention is better than attempting to cure a problem or crisis. And that's how I want you to view today's discussion, and hopefully it will change your behavior if I haven't, Dr. Alvarez and I haven't gotten you to do it already in the clinic. Okay, so we're ready for our first engagement by the audience. So questions, if you have none, I'm going to start quizzing the panel. So if you might, oh, we got one over here. Couple over here.
Comment.
Hi, Dr. Packard. I've had sleep behavior disorder since I was in my 20s, off and on. I was just wondering, could that have been a precursor to my Parkinson's disease?
So you acted out your dreams at night, yelled out.
Yes, sir.
I'm going to let Dr. Yankoff handle that question.
This is a proof now that 15 to 20 years is before the first symptoms of Parkinson can have REM behavioral disorder. Yes, this could be. If you have the Parkinson around 50, it's very possible. Because according to the hypothesis of Braque, the prion-like disease starts from the gut and goes all in the vagus, and the REM sleep is in the bulbar area. That's why it's very possible.
So the question was whether the sleep problems could have preceded and be part of it, and Dr. Yankoff said yes to that question. Next question.
Good morning. You had mentioned smokers having a reduced risk of Parkinson's disease. Is there any significant differentiation between cigarette smokers and cigar smokers, or does that factor in at all?
Dr. Alvarez, you want to take that?
There's not enough data, and also there's not enough data if cigarette truly helps, if the menthol works better than the filter cigarettes.
Thank you.
So it may have nothing to do with the smoke component, it may have to do with the nicotine, so anything with nicotine may be the reason. So yes, but no difference between cigars and cigarettes outside of the nicotine. Next question.
Hi.
Good morning.
No,
you can stay seated.
Okay. As a young child, I could not stand to be dizzy. Is that precursor?
So I heard dizzy.
Like all children, like to be spun around. I could never stand it. Never.
Yeah. So, and I say this in clinic, and I know Dr. Alvarez and Yankov also do. So when you talk to doctors or healthcare providers, you need to be really clear between dizzy, which to a medical person means lightheaded, woozy, if you're going to faint. Or maybe you might faint because you're so lightheaded. That's dizzy. Vertigo is where you make a sudden change, turn your head, roll over in bed, bend over to tie your shoe, and you have the sensation as if you got off a Ferris wheel or a merry-go-round. That's vertigo. So you need to be really clear that you don't use dizziness for vertigo or vice versa. Also, don't use dizziness or vertigo when you merely mean off balance, because you can be off balance without being dizzy or having vertigo. So we always have to be very specific in our language, and so I'd have to re-ask, do you mean lightheaded woozy as if you're going to faint? No, see?
No.
All right,
No,
okay.
I meant just dizzy.
Well, dizzy meaning off balance? Or does the room spin?
No, the room did not spin.
Okay, and you're not lightheaded and woozy as if you're going to faint.
No, I fainted once as a child at camp, but they said I was hungry.
Yeah. So it'd be hard to relate that to your present Parkinson's disease, but Yeah, but certainly balance problems are part of Parkinson's disease. Some Parkinson patients may have dizziness, lightheaded, woozy, as if they're going to faint when they stand. And aging is a risk factor for vertigo because of little stones that develop in the inner ear, and our therapists sometimes help that. So we need to just keep the language clear so that we do the right thing. So please take home that bit of information as well. Next question.
It's very interesting that you have these symptoms since childhood. And this most probably you have a dysautonomia. This meaning a disease is due that you cannot, but if you stand up, your blood cannot go up in the brain immediately. This is called dysautonomia and is expressed with POTS syndrome sometimes. It's very easy to diagnose this condition. If you lie down, if your pulse is 72, and if you stand up, if the pulse is more than 80, 88 or 90, this is the diagnostic. We do this with tilt tables, but every physician can do this in the office if they measure the blood pressure in lying position and in standing. This is a dysautonomia. This is not going usually with Parkinson. You may have two symptoms very different, dysautonomia and Parkinson. Or maybe your Parkinson is part of this dysautonomia complex syndrome, which is very complex and nobody understands very well. I don't know.
So I have a question for one of the board members here. So as we talked about getting into non-drug treatment, I'd like Kathy to comment on, does every Parkinson patient need to be assessed by physical therapy in general, or how would you guide patients to think about that when they're first diagnosed?
So I think the first way to answer that is I don't necessarily think every patient needs to be evaluated if you're not having functional problems that are interfering with your life. Although having said that, there's so many things to learn about the wellness aspect of it that it certainly is beneficial. And with regard, were you wanting me to address the dizziness question as well?
Sure. Yeah, you could address.
So I think there's a lot of underlying issues with, just with it, as with any disease, a lot of patients have underlying issues that aren't related to the Parkinson's, just like Dr. Yankov just mentioned. We see a very high incidence of vestibular problems with our Parkinson's patients. I didn't, as a younger therapist, didn't recognize these as vestibular problems. I thought they were just balance issues. But as you get more experience and learn more and find out what you didn't know when you were younger, you realize that a lot of it is related to vestibular issues. With regard to the question about the patient that asked, the client that asked about, talked about being dizzy as a young child, there's a correlation with people with motion sickness having vestibular problems as they age. So that it could be a vestibular problem, not necessarily vertigo, but just an imbalance in the fluid system of your inner ear. So that certainly can be addressed by physical therapists. There's several physical therapists in town that specialize only in vestibular, but most of us who do outpatient have a fair amount of experience with vestibular, so you can start there. And like myself, if I see somebody that's very complicated vestibular patient, I'll ask the physician to refer them to one of the 4 specialists in town that I know well. So I guess in answer to your question, Dr. Pepper, I think it's beneficial for everyone to have an evaluation. Probably if you've been diagnosed with Parkinson's, you're starting to have functional deficits. And with exercise being neuroprotective, we can teach you really some of the best ways to exercise, and we can address that more later as well. To get started on that, you don't want to wait to start exercising, certainly. The earlier, the better. And I think Dr. Powell would agree, you should also tell your children if you have Parkinson's that they should be aggressively exercising as neuroprotection for them. So does that answer your question?
Yes, thank you.
Okay.
Sure.
So I just want to second Kathy. I think the research that's out there right now actually says everyone who does have Parkinson's should see a physical therapist. Early on, the earlier the better, because sometimes there's things that you may not notice that are related to Parkinson's. We just had a workshop last weekend and talking with some of you who are here, as we describe things that are common for Parkinson's, I heard